All right, let's dive into a really important paper from Patterson and colleagues that appeared in the Journal of Orthopedic Trauma. It's one of those studies that takes a hard look at something we deal with all the time, managing displaced femoral neck fractures in our younger patients, and, well, it really challenges some of our core beliefs. What they've found has some serious implications for how we might approach these in the OR.
To really get a sense of how big this problem is, the paper itself brings up this classic quote from Sir Astley Cooper. And it's so true, isn't it? Even now, a couple hundred years later, this is still, in so many ways, the unsolved fracture. For a young, active patient, the stakes just couldn't be higher. A bad outcome here, well, it's just devastating.
So let's get right to it. We're in the OR, that X-ray is up on the screen. What's the big decision point for all of us?
Yeah, it really boils down to this, right? Do you spend the time trying to get a perfect closed reduction, or do you just make the call to open it up? We're all shooting for the same thing, an anatomic reduction, because we know that's what gives our patients the best shot. But how to get there, well, that's been the debate for decades.
And this is the classic trade-off we all learned, right? The thinking has always been, you open the fracture, you can see everything, you get that perfect anatomic reduction. But the big fear is that in doing so, you're disrupting that already fragile blood supply to the head. On the flip side, you go for a closed reduction to preserve that blood supply, but you're always wondering, am I accepting a less than perfect reduction? And we all know that's a recipe for failure. So, this is exactly the question that Patterson and his team set out to answer. Let's take a look at how they put this study together, because it's pretty solid. Okay, so this wasn't just some small, single-center study. We're talking about a big, retrospective cohort from 12 Level 1 trauma centers across North America. They looked at 234 adults, all with these tough, displaced femoral neck fractures. And their primary outcome was simple, objective, and really the one that matters most to us and our patients: reoperation. It's level 3 evidence, so it gives us a great snapshot of what's really happening out there in the real world.
And this is where things get, well, pretty counterintuitive. Logically, the authors thought that an open reduction, aiming for a better reduction, would lead to fewer reoperations. Makes sense, right? But that's not what the data showed at all.
So here's the headline number. After they crunched all the data and adjusted for all the variables like how old the patient was or how bad the fracture was, they found that one approach had a 2.4 times higher risk of needing another surgery. That's a huge difference. And this graph really paints the picture. It's a Kaplan-Meier curve, and you can see right away how the two lines split. That top line, the one for open reduction, it just takes off early and stays way higher. This shows a much greater chance of needing a reoperation over 2 years compared to the closed reduction group. This isn't a small, borderline finding. It's a pretty stark difference. Okay, so why? What was causing all these extra trips back to the OR? When you look at the reasons, one thing just jumps off the page: non-union. We're talking a nearly 4-fold increase in the open reduction group, 16% versus just under 5%. That's a huge, statistically significant difference. And what's just as interesting is what didn't change. The rates of AVN, fixation failure, malunion, they were basically the same between the two groups. The problem here was all about the fracture not healing. So this immediately makes you ask the obvious question, right? If we're opening these fractures specifically to get a better reduction, how on earth did it lead to a worse outcome? Let's dig into that. The entire justification for taking the risk of an open approach is that it results in a better quality reduction. But does it? Is that assumption actually true? Well, according to this study, the answer is a pretty clear no. And this is probably the other huge finding here. They had a panel of senior surgeons who didn't know which was which look at the post-op X-rays. And guess what? There was no significant difference in the quality of the reduction. About 71% were acceptable in the open group and 69% in the closed group. So that core belief, the main reason many of us would choose to open, it just wasn't borne out by the data here. Okay, so let's put this together. If opening the fracture doesn't actually give you a better reduction, but it does lead to a much higher non-union rate, what's going on biologically? Well, the authors have a pretty compelling hypothesis. We're causing the problem ourselves. It's an iatrogenic vascular injury. The surgical approach itself, whether it's an anterior or anterolateral one, can damage the blood supply. The very act of putting retractors in can strip the periosteum and injure those crucial retinacular vessels. It all adds up to devascularizing the fracture site, and that can be the very thing that pushes it towards not healing. So let's bring this all home.
What are the big takeaways? How should this study make us think differently when we're standing in the OR?
You know, one of the most eye-opening things in the whole paper might be this graph right here. It shows just how differently each of the 12 centers approached these fractures. I mean, look at that variation. You had one center that did an open reduction on every single one, and another that never did. It really suggests that a lot of the time, the decision to open or not has more to do with where you trained and what you're used to, rather than the specific patient or fracture in front of you.
Now, of course, we have to be critical and look at the study's limitations. It is retrospective, so there's always a risk of selection bias, though they did a good job trying to control for that with their statistical analysis. And yeah, they lost a lot of patients to follow-up, but let's be honest, that's pretty standard for this patient population. They can be tough to track down. Okay, but this next point is absolutely crucial, and the authors hammer it home. This study questions the routine use of open reduction. What it does not do is give anyone a pass to accept a bad closed reduction. Let's be perfectly clear. Pinning a malreduced or unreduced femoral neck fracture is, and always will be, completely unacceptable. That standard hasn't changed one bit.
So, where does this leave us? It really forces us to question our default settings, doesn't it? The study suggests that if you can get a good closed reduction, you should probably take it. So the real question for our practice becomes, when do we truly need to open? What are the real evidence-based indications? This paper doesn't give us a license to be lazy, it gives us a reason to be thoughtful. And that's the question we should all be asking ourselves the next time one of these fractures comes through the door.